It's a real honor to be here with you on the 10th anniversary of the celebration of Overcome and to participate in this educational event. So thanks very much. So Runzi asked me to talk about rare ovarian cancers and give you some updates, which I'm happy to do. And I think we have made great progress over the past decade or so. So I always like to show this slide, which shows you the clinical trials conducted by the main cooperative group for gynecologic cancers, the GOG, over a 3-decade period. And what you can see is that during this period, all ovarian cancers were treated identically. It didn't matter what subtype, whether it was serous, clear cell, mucinous, they all received the same treatment. But in the early part of this century, we began to understand the heterogeneity and to learn that ovarian cancer is not one, but several distinct subtypes. And these advances in the heterogeneity were through pathologic studies, advances in the molecular biology, and also hypothesis-generating clinical studies. And importantly, in 2005, the GOG started the Rare Tumor Committee. I had the honor of being the first chair of that committee. And we began to develop separate clinical trials for some of these rare subtypes. And then this kind of concept was validated by a couple of international groups subsequently. And you saw this from Dr. Drapkin, but there are basically 4 subtypes of epithelial ovarian cancer, although I will say there are 5, because if you look at serous, that's divided now into high-grade serous and low-grade serous. And Dr. Drapkin talked primarily about high-grade serous. High-grade serous constitutes 90% of serous cancers, whereas low-grade serous carcinoma is only 10%. And then the other 3 rare subtypes are endometrioid, mucinous, and clear cell. And we've learned a lot in the last few years about the molecular biology of these rare subtypes. High-grade serous has p53 mutations, is associated with hereditary BRCA mutations, but the other rare subtypes have very different profiles. Low-grade serous has KRAS, BRAF, and NRAS mutations, clear cell carcinoma, mainly ARID1A mutations and PIK3CA mutations. Endometrioid is similar, and then mucinous carcinoma, mainly KRAS or other abnormalities. So I'm going to use the NCCN guidelines to talk a little bit about all 4 of these rare subtypes, because that's the standard within the United States for setting treatment recommendations. And so first of all, this is clear cell carcinoma from the NCCN guidelines. And what you can see there is for all stages, the recommendation post-operatively is for platinum-based chemotherapy. This happens to be a very rare subtype. It's very aggressive. And in fact, the most aggressive of all of these 4 subtypes. And so we need to make progress, particularly in this one. And I think that has occurred. In my view, there's been a real breakthrough in the last few years for treating a clear cell carcinoma. This was a report from 2015, and this is one case, a 60-year-old woman with recurrent platinum-resistant clear cell carcinoma of the ovary treated with immunotherapy, with nivolumab. And what you see here, the CT scan on the left shows you that she had a complete response over a period of 4 months, and her CA-125 went from 316 to completely normal. Well, that report launched a series of clinical trials throughout the world for immunotherapy in the treatment of clear cell carcinoma of the ovary specifically. This happens to be, actually, this is a trial of pembrolizumab, a very commonly used immunotherapy drug. All subtypes of ovarian cancer happen to be included in this trial. But in fact, when they analyzed the data, they found that the highest response rates were found in clear cell carcinoma, and the other subtypes really had very low and disappointing response rates. And this early data has also been shown in other clinical trials preliminarily. But in my view, this has been a major breakthrough in the treatment of this very aggressive subtype clear cell carcinoma. And we look forward to the results of some of the ongoing trials. Second type is mucinous. Now, mucinous carcinoma is also difficult to treat. It's not very sensitive to platinum-based chemotherapy, at least with the standard of paclitaxel and carboplatin. As you can see there, if the disease is limited to the ovary or ovaries, the recommendation is observation. But for most of the other stages, it would be systemic therapy. A few years ago, the British and we in the US through the GOG collaborated on this clinical trial for women with mucinous carcinoma, understanding that the results with the standard treatment were pretty poor. And we randomized women to the standard treatment, carboplatin paclitaxel for 6 cycles, followed by bevacizumab, which is Avastin, or no bevacizumab, versus a regimen that's used for gastrointestinal cancers, because these microscopically look somewhat like gastrointestinal cancers. And this was oxaliplatin capecitabine with the same secondary randomization. Unfortunately, this trial closed early because of poor accrual. And the reason for that is the investigators overestimated actually the number of women with mucinous carcinoma. And in other words, it turned out that it was much rarer than we had previously thought. So this trial represented pretty much a failure. But there have been some subsequent reports that have given us hope. And this is a retrospective study from Johns Hopkins and MD Anderson Cancer Center, in which we accrued 52 women. This was not a clinical trial, it was a retrospective study. Half of the women had received the standard paclitaxel carboplatin type regimen, and half had received a GI type regimen for their chemotherapy. And what we found was that the results were superior for those women in terms of progression-free survival and overall survival for those women who had received the GI type regimen. And so this was very heartening, and we believe that moving forward, these regimens need to be studied in larger cohorts of women to see if they really do represent an advance. Thirdly, endometrioid carcinoma. Now, this probably of the 4 rare subtypes is the least studied of them. The high-grade endometrioid carcinomas are generally lumped with high-grade serous. They tend to be, again, fairly aggressive, whereas the low-grade endometrioid carcinomas are more indolent or slow-growing. And this is an algorithm for a low-grade or grade 1 endometrioid carcinoma. You can see that observation is used in the early stages and recommended. And then in the more advanced stages, it's either chemotherapy or hormonal therapy. But we've not, as I say, we've not studied this as much as we need to. This was a study that was actually reported earlier this week by an investigator from the UK. That group is studying endometrioid carcinoma. And what they have found is that when they looked at hormonal receptors, estrogen receptor, progesterone receptor, and then correlated that with next generation sequencing, mainly P53 and as well as some other genes, they found that they were able to subset patients with endometrioid carcinoma into risk groups. And those who had a high PR as well as a wild type P53 had a better outcome. And so I think this gives us hope that we are beginning to make advances in the study of endometrioid carcinoma as well. And then the fourth subtype to discuss is low-grade serous carcinoma. This is one that I've spent the last decade or so studying, and will try to present some more detailed information. This also tends to be a slow-growing or indolent carcinoma. For stage 1, confined to the ovary, the recommendation is observation because the prognosis is excellent for those women. However, most women with low-grade serous carcinoma, just like for high-grade serous carcinoma, present with advanced stage disease, primarily stage 3 or even stage 4. The standard treatment for several years has been chemotherapy with paclitaxel and carboplatin, but I'm going to show you some data that have led us to change the treatment paradigm. So this is a little background about low-grade serous carcinoma. It may arise de novo or following a diagnosis of the precursor serous borderline tumor. As I mentioned before, it accounts for about 10% of all serous cancers. And these are the features that distinguish it from high-grade serous carcinoma. So women are younger at the time of diagnosis. Low-grade serous carcinoma is relatively, not completely, but relatively resistant to conventional chemotherapy. So we need to look for other treatments. There is a very high frequency of estrogen receptor expression, and about 50% of tumors express the progesterone receptor, which means that it may be actually responsive to endocrine therapy, which it is. Also, there's about a 50% frequency of mutations in what we call the MAP kinase pathway. And primarily, these are KRAS, BRAF, or NRAS. We know that low-grade serous carcinoma is associated with a prolonged survival compared to high-grade serous carcinoma. So the average survival for women with this cancer is 8 to 10 years, and actually some of our recent studies indicate that it's even longer. However, as I mentioned, most patients are going to present with advanced stage disease, and over 70% will relapse during some time in their clinical course. So this is a study from Australia reported last year, in which the investigators found that almost 50% of low-grade serous carcinomas did have a mutation in either KRAS, BRAF, or NRAS, and there was a very high expression of both estrogen receptor and progesterone receptor. In 2015, our group reported this study that showed that women whose tumors contained either a KRAS or a BRAF mutation had a significantly better overall survival than women whose tumors did not, who had wild-type KRAS or BRAF. And then there was a study, the Milo study, which was a clinical trial that I'll mention in a moment, that showed if a woman's tumor with low-grade serous carcinoma contained a mutation of KRAS, that they were more likely to respond to a MEK inhibitor, which is a targeted drug that actually targets precisely the MAP kinase pathway. In 2017, there were 2 studies that were reported, both retrospective, one from our group at MD Anderson, 203 patients, all of whom had primary surgery, 133 then received paclitaxel carboplatin chemotherapy, and then went on to observation or surveillance. 70 patients, on the other hand, after surgery and chemotherapy, went on to receive hormonal maintenance therapy. And what we found was that those patients who received the hormonal maintenance therapy had a prolonged progression-free survival, meaning they did not recur on an average of 65 months. Whereas the women who just received chemotherapy without hormonal therapy recurred within 25 months. The Johns Hopkins study reported on 27 women who again underwent primary cytoreductive surgery and then immediately went on hormonal therapy, no chemotherapy at all. And their results were provocative and showed very similar outcomes to the ones in the MD Anderson study, although their follow-up was not nearly as long. And these two studies served as the basis for the development of this upfront or frontline clinical trial in which women who undergo primary cytoreductive surgery and have stage 2, 3, or 4 disease with low-grade serous carcinoma are randomized to either chemotherapy for 6 cycles, followed by letrozole maintenance therapy until disease progression, versus letrozole alone until disease progression. This trial now has accrued 140 women. The target is 450, so it's going to run for another 3 years or so. But this trial may indicate, once we have the results, that chemotherapy is no longer needed for the frontline treatment of low-grade serous carcinoma. This is a study, again, just with hormonal therapy for women who present with a very extensive advanced stage low-grade serous carcinoma, so no chemotherapy at all. Prior to surgery, they are being treated with fulvestrant, which is an estrogen receptor blocker, along with a CDK4/6 inhibitor, abemaciclib. This is a combination that has been used for the last several years in breast cancer and has shown remarkable progress in terms of outcomes for women with HR-positive breast cancer. And the preliminary results of this pilot study are very interesting, and we've seen a much higher response rate than we have observed with chemotherapy in this population. For the treatment of relapsed low-grade serous carcinoma, these are basically our 4 options: endocrine therapy, chemotherapy, the drug bevacizumab, which is an anti-angiogenic drug, or MEK inhibitors, again, a targeted agent for the MAP kinase pathway. The endocrine therapy options include the aromatase inhibitors such as letrozole and anastrozole and exemestane, as well as fulvestrant and other agents. But the primary drugs that are used initially are the aromatase inhibitors. This is an ongoing trial, again, based on the experience with HR-positive breast cancer, in which we are combining letrozole, the aromatase inhibitor, with ribociclib, which is a CDK4/6 inhibitor. This combination, again, has been used with great success in HR-positive breast cancer. This trial, we think, will complete accrual within this year, and we've already had several responders, and we are very hopeful that it will represent an advance in the treatment of women who have recurrent low-grade serous carcinoma. Then there are 2 trials, 2 phase 3 trials that studied MEK inhibitors for low-grade serous carcinoma in the recurrent setting. This is the MILO trial that compared the MEK inhibitor benimetinib to physician's choice chemotherapy. Patients were randomized. Unfortunately, because of the design of this trial and the overestimation of, or rather the underestimation of the outcomes for the women who received the chemotherapy, there was no difference in the 2 arms. And so the MEK inhibitor did not provide any advantage over chemotherapy. So this was a negative trial, unfortunately. Although, as I mentioned, the investigators did show that if women's tumors contained a KRAS mutation, they were more likely to respond to benimetinib. The GOG 281 study was similar, used a different MEK inhibitor, trametinib instead of benimetinib, and patients were randomized 1-to-1 to that MEK inhibitor or one of these 5 standard of care options. There were 2 hormonal agents and 3 chemotherapy agents. And this was a positive trial. In fact, it's the first positive trial in the treatment of recurrent low-grade serous carcinoma that's ever been reported, or for that matter, the first treatment of any type for recurrent low-grade serous carcinoma. And we found that the median progression-free survival was about twice what it was for the women who received one of the standard of care options. And this is an option that is available now for women off protocol. This is an ongoing study, an exciting study also that combines a dual RAF/MEK inhibitor that again targets the MAP kinase pathway with another drug, a FAK inhibitor. And the preliminary results from this trial look also very exciting. And so we're looking forward to the final results. But as I say, this is an ongoing trial for women with recurrent low-grade serous carcinoma. We reported at the SGO meeting last week a study of 215 women who were profiled with low-grade serous carcinoma with next-generation sequencing. And what we found was that the women with MAP kinase mutated tumors, so primarily a KRAS, BRAF, or NRAS mutation, had a significantly better outcome, both in terms of progression-free survival and overall survival compared to those women without a MAP kinase mutated tumor. So this is prognostic information that will be very helpful in allowing us to develop further studies to improve treatments for women with low-grade serous carcinoma. The other thing we observed in this study is that younger women younger than 35 years of age, actually had a worse prognosis than older women. And again, this has been observed in HR-positive breast cancer as well. I would emphasize that there are certainly exceptions to this rule. These are the gene mutations that we found. We found 201 mutations in 140 of the 215 patients. 75 of the patients' tumors had no mutations at all. And again, the most common were KRAS, NRAS, and BRAF. And finally, this is a study that's ongoing that we're reviewing 97 women diagnosed between the years 1996 and 2019 who received what we consider to be contemporary treatment. And that would include primary cytoreductive surgery, followed by either chemotherapy, followed by hormonal maintenance therapy with an aromatase inhibitor, or an aromatase inhibitor alone. And letrozole would be the most common aromatase inhibitor that's used today. And what we found was these patients had a median progression-free survival of 53.6 months and a median overall survival of 130.7 months. So actually better than previously reported. 45 of the 97 women have not developed either disease recurrence or progression. And of those 45, 43 of the women are completely without evidence of disease. And so these data really, I think, represent new findings, and we are very hopeful that we are going to be able to actually cure more women with the introduction of endocrine therapy into frontline treatment. What we also have found in this study is of the women who recurred, that most of them, in fact, 95% of them recurred within 5 years. Only 3 of the patients recurred after 5 years. And so that gives us some benchmarks and information that we had not previously observed. Finally, the BOUQUET trial is an ongoing trial. This is for women with all 4 of these rare ovarian cancer subtypes. These would be, the eligibility include women who have recurrence with the low-grade serous, endometrioid, mucinous, or clear cell carcinoma. They undergo profiling with next-generation sequencing with Foundation 1 sequencing. And then based on the results of that sequence, They are randomized to one of these arms, one of these 4 arms. There are also going to be 4 additional arms that will be added to this in the very near future. So this is an exciting study. It's the treatment is based on the molecular profile of these rare ovarian cancers. This is an international study, and MD Anderson will be opening this study in the very near future. So in conclusion, there's been a major paradigm shift in the study and treatment of rare epithelial ovarian cancers over the past 2 decades, particularly the last 10 years. Our understanding of the biology of rare epithelial ovarian cancers has led us to significant advances in treatment so far. And I believe that the future's never looked brighter for women with these rare ovarian cancer subtypes. Importantly, I believe that these advances have stimulated interest of investigators as well as pharmaceuticals to focus more on rare ovarian cancers. And in fact, for low-grade serous carcinoma, we have observed this phenomenon very much in the last couple of years. However, there's much work left to be done. So thank you very much for your attention. I'd just like to acknowledge the patients and their families that have contributed to all this work, as well as our funding sources. Thank you very much.